bottom, you have an interpretation option, and that's where you choose the language you want to listen in, either English or Spanish. If you choose neither, you will get the language that the speaker is speaking in. So that assumes you're bilingual, then you can choose neither.
Listo. Buenas tardes a todos.
Good afternoon, everyone. We're very grateful to be presenting to you today. We're very excited about this opportunity. I introduce myself. I'm Dr. María Fernanda Tapia, plastic surgeon of the University in Colombia, and my colleague, John Dutton, general surgery resident at Rutgers from New Jersey. We are both fellows in global surgery with Operation Smile. Very happy to discuss this topic. How to make sense out of surgical indicators. We know that in public health, let's go to the previous slide. Low and medium income countries have high degrees of infectious disease. Surgical treatment opportunities have often been abandoned by public health systems. The developed countries and NGOs for years have been working to support this treatment. They usually do it through surgical missions, short term, but they have not been prioritized in public health policies. And as a result, there are huge economic and social consequences. And we are working to develop the NSOPs, National Surgical Plans. Since 1980, then UN WHO director has highlighted access to surgery as a high priority. Dr. Paul Farber and Dr. Kim Park have defined surgery as the abandoned stepchild and developed this program in support of global surgery. And they've now highlighted, the WHO 6815 has highlighted the huge disability caused by lack of surgery.
Poco después, la resolución de la Asamblea Mundial en Salud del 6815,
the 68.5 resolution then defined safe, affordable, and high-quality surgical care as an essential part of universal health care. The efforts to provide surgical care have now pivoted to more sustainable work by reinforcing local surgical systems. Now, many academic institutions work with local providers to provide infrastructure, education, and other work beyond mission trips. The Lancet Commission developed a format for systematic development of national surgical obstetric and anesthesia plans. To plan and implement these NSOPs, or surgical plans, there is an 8-step plan. The first step is to develop the base indicators, to be very clear about the status of surgery, and then evaluate the changes needed and the needs for new policies. The 6 surgical indicators identified in the Lancet Commission try to identify the current situation in each country and the effect of them on the economy in the country. The first step to the development of surgical plans is to gather data we're going to look at what has been done in Latin America in these past 6 years. Since 2016, many people interested in this topic gathered together with North American institutions in Sao Paulo, Brazil, to do a systematic analysis in these countries and developed a plan for regional coordination. They then developed the LARC, cross-sectoral research units. These are made up of students, residents, fellows, and specialists, both from North America and from Latin America, working towards strategic plans to reinforce the local surgical systems, to analyze results, and to build these plans, to build these national plans. After this, in 2019, this article was published that presents the base data collected in the region. In Bolivia, the researchers discovered that they didn't have the basic, they decided to change the indicators to the system used for basic trauma data. They gathered information from the most important cities and from the morgue to determine data for trauma, and they realized they did not have the correct information. In Brazil, it is the only Latin American country that has been able to collect the data. They did such a good project, they were able to distribute the data to every region. The Amazonas University, together with Harvard and Sao Paulo University, were able to develop indicators to measure the quality of care. In 2019, they met surgeons, anesthesiologists, gynecologists, and created the regional NSOPs. Colombia is the second country that did a situational analysis. It was published in 2020, and we're going to present a detailed summary of this publication. It is important to highlight that this effort was led by university students and supported by Colombian surgeons. Ecuador has a public health system, universal health care, for more than 12 years, but the rural areas have very limited surgical care. And there was no system to collect data for the indicators. But they have started efforts with prestigious universities, with support from students and organizations and others, and they now have a collaboration to collect data based on the Lancet Commission. The cooperation from Haiti has reported a lot of difficulties in the current Haitian healthcare system. As of now, there is no way to collect the data that's needed. In Mexico, the Spanish hospital of Veracruz established a global surgery research center to undertake clinical research on surgical indicators. And together with LARC and other research groups, they're carrying out studies in the city of Veracruz. and studying the health system and public policies throughout Mexico. In Nicaragua, in 2015, a movement was started in support of safe surgery to improve surgical access throughout the country. A year-long training process was organized to improve training for surgery. 2017, they started a program, Surgery for the People, and adapted equipment and training in rural hospitals in the region of Las Minas. Through this effort, they were able to gather a lot of surgical indicator data. As a result, we can see that to date, there are only 2 countries, Brazil and Colombia, that have complied with this first step of the Lancet Commission. Brazil is really the only one that was able to do this through their own national effort. We understand that gathering this data of surgical indicators is not easy, but it needs a lot of support, national and regional. To show an example of how we can do this, we can see the results of a collaboration among countries of the Pacific region based on the surgical systems in several countries. The Surgical Society of the Pacific Islands and another group worked together as a team. They were able to create working groups with a clinical researcher from each country, and they carried out field research. For the first indicator, they identified all the countries that could provide the basic care, and they cross-analyzed transportation with population centers, all to analyze how close they are to achieving the 80% access for 80% of the population to care. They found that many communities can get access within 2 hours, but many areas are lacking personnel and supplies and facilities. For the second indicator, we took information from data collected by specialists. We found that only 4 of the 14 countries studied had all of the 20 specialists that they needed. They suggested that efforts be concentrated to develop more specialists and to make note of many surgeons who are providing this care, even if they are not the indicated specialists. Regarding anesthesia, some countries have reporting systems and others don't. They went through all of the anesthesia logs. They recommend a minimum standard for yearly reports. For the fourth indicator, regarding mortality for any reason, for hospitals that did not have these records, they did a 6-month review. Seeking the method is mortality less than 11%. And they're seeking to make sure that all the hospitals have a registry system and are reporting the data in a timely manner. Indicators 5 and 6 were not yet collected, but we made calculations based on Bajo models and found very wide-ranging ranges, very wide differences of health coverage among the different parts of the different countries. The authors summarize some of the challenges that came from this process. We know that this region has some very small populations and then some as big as 24 million. It will be a huge challenge for the countries that have very large cities. We will not achieve the goals of the Lancet Commission without continued missions and support. And we need efforts to motivate this work. None of the countries has a system that allows us to get immediate access to surgical indicator data. And individuals have to put in a lot of effort to make it possible. 6 years since the publication of the Lancet Commission, many of the countries have still not even started developing NSOAPs. They are struggling to find even a baseline. Recognizing this, groups decided to develop a very clear definition of the distinct indicators to make sure that the data within the same countries and compared with each other is comparable. The current panorama shows very few of the countries have significant data available. For example, about perioperative mortality, only 9. An expert committee gathered to talk about this problem. Experts from different fields from 40 different countries and included the authors of the Lancet Commission. The idea was to figure out a way to simplify and make this process more relevant to local public health and to avoid unintentional negative consequences. Regarding the methodology, working groups were established. Regarding access to surgery, maps were developed to identify which hospitals can carry out the bellwether surgeries and to map out the transportation time from where the people live to these hospitals. For the second indicator, each of the different elements of the ENSO are proposed to be separated and to divide it up per 100,000 inhabitants. We'd also like to better gather information on how many surgeries in each type of surgery are happening in every hospital. Also trying to identify deaths caused by, for any reason, within 30 days of a surgery or any procedure for which anesthesia is used. Regarding the financial protection indicator, tried to carry out national surveys about all of the expenses around that patients are covering around accessing surgery. If a patient is spending more than 10% of their income to access their surgery, it's considered catastrophic expense. As we see, there is not one country in Latin America that has a complete ENSO or that has established a budget to obtain it as a part of their public policy. We believe that the global surgery community needs to reinforce its network and its lobbying to achieve these. Working not only with health authorities, but with the global community in general. We need a standard procedure in Latin America for gathering surgical indicator data. And many countries in the region are going to need some type of finance. And the countries that are more advanced in the ENSO development should be lobbied to help the other countries in the region. The data collection can be assisted by teamwork, and we need the entire community, including NGOs, academic institutions, and others to work together.
Great. So, Jody, do you need some time to switch over? So thanks so much, Maria. As Maria has outlined and discussed previous work throughout lack of understanding the indicators, it's important to recognize a major accomplishment that came out of strong international collaborations between stakeholders in Colombia and Rutgers University. This study that you can see here on the slide is the first complete non-modeled indicator situational analysis and the first to contextualize a surgical system using the 6 core surgical indicators. Prior to this study, non-modeled national analyses utilizing the Commission's indicators in middle-income countries was really difficult because there's a lack of robust healthcare information management systems. This study also evaluated the correlation between the core surgical indicators and socioeconomic status. Before really diving into the results, it's important to note that the researchers of this paper utilized several non-connected national database repositories from 2007, 2014, and 2016 to generate conclusions through large data processing and analysis. While this is an excellent study and one that is so pivotal and needed to showcase the possibilities of what insights can be generated with the surgical indicators, the study also highlights that there are still large gaps in reporting of timely and comprehensive information surrounding the surgical indicators that allow for present-day insight into surgical healthcare systems. So looking at the results, they found that almost 15 million people in Colombia were without access to surgical care, and that the most disadvantaged areas had no residents within 2 hours of a bellwether facility, and that there was a negative correlation with the percent enrollment in a subsidized insurance regime. So basically, the higher the percent of the population with a subsidized insurance, the less likely those municipalities had a bellwether facility. Regarding indicator 2, they found that 86% of the municipalities did not have a surgeon, an anesthesiologist, or an obstetrician registered to that area. When looking at the SAO density and the progress Colombia has made over the past few years, it appears they are making progress, and they are, but you have to take this data with a grain of salt, because as you break down the numbers by municipality, you see a wide range of the SAO providers available, with the highest density still being in the larger urban centers. In contextualizing indicator number 2, they again saw a negative correlation between available SAO providers and those municipalities with individuals of lower socioeconomic status. In assessment of indicator number 3, there were 1.4 million procedures performed in 2014. They found that the Colombian system still had a 40 to 50% gap in achieving the recommended number of procedures per 100,000 population, and only 6% of the municipalities were within a reasonable range of meeting that target of 5,000 per 100,000 population. Regarding indicator number 4, They were able to calculate a perioperative mortality rate. However, this was done by cross-referencing patient-level surgical data with national mortality data. And if a patient died within 30 days of a surgical procedure, they were included in the study. There are no current centralized or connected databases to gain a true perioperative mortality rate without a significant effort of time, resources, and data analysis. And finally, regarding indicators 5 and 6, the risk of impoverishing expenditure ranged from 3 to 13%, with a 6% increase when out-of-pocket expenses were considered for surgical services. This data also provides insight into the indirect costs and the increased risk of impoverishing and catastrophic expenditures when indirect costs are taken into account. The study found that 19% of the population was at risk of a catastrophic expenditure if they were admitted to the hospital and were in need of surgical services. This data provides some really incredible insight into the economic costs that care can have on individuals needing surgical care. However, it is important to know that this data was generated from a 2000 National Health Survey. These numbers are more than likely to have risen since that time, with a significant increase in the percent of population below the poverty line in Colombia over the last several years, which has no doubtedly been exacerbated by the current global pandemic. Besides the gaps already discussed, the top 2 points you see on this slide showcase that the incidence of poverty is associated with a lower likelihood of being within 2 hours of a bellwether facility or of living in a municipality without an SAO provider. This study provides evidence that the association and correlation of these core surgical indicators with socioeconomic status based on insurance regimes are consistent with known social determinants of health. And it also validates the use of the 6 core surgical indicators for the development and implementation of a national surgical plan. While the study was needed to help provide context to why the surgical indicators must be collected to generate a baseline understanding of surgical systems throughout LAC, it is worth mentioning again that the study highlighted an ongoing gap of interconnected data systems in which this information can be easily generated to understand a current up-to-date baseline and further progress over time on the path to 2030. Okay, so we talked about this incredible group of stakeholders that were able to generate a non-modeled study of the indicators. But now the questions are, what's next? Where do we go from here? I think it's important to address the elephant in the room. Largely, much of the work discussed thus far and the data collection described has been led by academic institutions. Funding is competitive and often not sufficient to provide funds to implement programs at scale over long periods of time, as is really needed to understand the impact of programs in real-world settings that attempt to address broad surgical indicators as discussed. There remains a disconnect between data gathering and baseline assessments, and what are the next steps past baseline assessments? How do we implement programs and activities to address found gaps? Countries throughout sub-Saharan Africa have been successful in passing policy and creating NSOPs, but a large gap continues to be the financial support needed to carry out these plans. We all know these key messages and the associated numbers. And as global and public health advocates, we understand the importance and the impact of not addressing these gaps. So why is there still a disconnect between these numbers and the powerful action plans being led by governments throughout Latin America and the Caribbean? I was traveling with another Operation Smile fellow 2 weeks ago, and her parents were from Pakistan, and she's very invested in the Middle East. And she, through her connections, she was having a conversation with one of the ministers of health in one of the largest provinces in Pakistan. And when she brought up the NSOP, which Pakistan is moving forward with, this minister of health turned back and said, well, what's an NSOP? What are you talking about? And I think this example highlights that the information that we're talking about today is still extremely siloed. We exist in a very small community, and really then it becomes our responsibility to break those silos and engage in and educate the key stakeholders that are required to make progress within the regions we work. Another disconnect is that NSOPs have large ticket prices without truly understanding what will work and what will not. Cross-sectoral large investors are unlikely to invest in plans that lack hard data, lack proof of concepts that are poised to be sustainable and scalable within the market segments or health systems they hope to impactfully provide positive change. We have to start targeting specific interventions, which many on this call may be doing throughout LAC, but how many, especially on the academic side, have the funding that once gaps are realized, they can implement a program, rigorously collect quality data, adjust the program based on local context, and then scale that program to a region or a country, and again, rigorously test if what worked at the local level also works at the regional and international level. There's also a high requirement of money and resources needed to understand if even a small program will work, let alone if it is cost-effective, sustainable, and scalable. In prior experience, I have a large background in product development through a few medical startups. And when I started my second company, this was a discharge processing platform that automatically connected outpatient services to patients prior to discharge from the hospital. Our slogan was, discharge planning starts on admission. And I think this saying can be translated here. Despite us still advocating for baseline assessments in 2021, we must start planning next steps now and not delay our plans for implementation until baseline assessments are complete, or we're not going to achieve the goals set for 2030. As a global surgery fellow for Operation Smile, I've had the fortunate experience to be involved with programmatic teams around the world. I get to interact with experts in strategy and operations on a daily basis, and we work in partnership with our local teams to come up with models of care delivery that share a common vision, but are locally adapted to increase our chances of successfully providing more care for more patients closer to where they live, while also helping to build the surrounding surgical system to not just only help the patients with cleft, but also provide essential and emergency services to their families and their surrounding communities. One example of how Operation Smile is doing this is our Global Essential Surgery Project. This is a large health system strengthening project focusing on building surgical capacity in a range of healthcare systems in Nicaragua, Madagascar, and Vietnam. We aim to improve surgical care through the delivery of equipment and supplies, renovating or building new medical infrastructure like operating rooms and PACUs, and delivering medical provider education and training. As an organization, we are shifting our focus to better meet and address the current global surgery agenda. We have many ongoing projects that aim to address both the supply and the demand side factors. It's important to not only solely focus on increasing capacity on the hospital side, the supply side, but also important to understand the patient side, the demand side, through investigations of barriers to care, the educational needs and gaps in the community with the community leaders and the community health workers. But also, it's important to understand the perceptions of our patients and the community's understanding and fears of surgery as well. Many of our ongoing projects have 3 phases. Phase 1 being a baseline assessment and recruitment of local teams and champions. Phase 2 being implementation of activities and interventions based on the gaps identified during phase 1. And phase 3 being an assessment of program impact and success with transition to local sustainability. Some may ask, well, why is Operation Smile getting involved with essential and emergency surgery? They're predominantly a cleft care organization. And my answer to that is cleft lip and palate is one of the 44 central surgical conditions as described by Disease Control Priorities 3. It's not cleft or essential surgery, they are the same thing. If you think about bellwether procedures, these are largely transactional patient procedures. A patient may be involved in a car accident, suffer an open fracture, be fortunate enough to be sent to a hospital that is able to manage their injury, but after discharge, that patient may never see the surgeon again, and the surgeon may never see the patient again. In comparison, a patient with clefts hits so many parts of the healthcare system. Our patients encounter providers across the prenatal, perinatal, postnatal environments. There is a need for preoperative assessments with pediatrics, dentistry, speech therapy. The patient with cleft has an average of 4 to 6 surgeries throughout their life. They're interacting with plastic surgeons, upskilled general surgeons that have been trained in cleft lip and palate, anesthesiologists, pediatric anesthesiologists, nurses, biomedical engineer technicians that are maintaining the needed equipment for evaluating and caring for our patients. Through the various parts of the healthcare system our patients connect with, there's an opportunity for intentional investments to lift the capacity, improve the system in partnership with our local teams around the world. And from a business standpoint, do our patients hit every part of the healthcare system? No. But we hope that through our more intentional focus in building up the specialties in which our patients interact with, we can provide a pathway for other NGOs and organizations to follow suit so that we together can comprehensively build the healthcare systems we work and provide equitable healthcare no matter where you live or how much money you have. In the Las Minas region of Nicaragua, located in the Central Atlantic region, it's about 12 hours northeast of the capital, we're doing what I just described. The project has trained more than 1,000 healthcare workers. We've constructed new operating rooms. We've implemented safe surgical protocols and engaged local communities to increase health-seeking behaviors specific to surgery. This has led to a 58% increase in surgical admissions, a 73% increase in essential surgical procedures. And of note, that 73% increase is in primary level, district level hospital procedures, meaning that we're seeing a 73% increase in the basic, or the 27 out of the 44 essential surgical procedures that patients truly need in the remote area of Nicaragua where we work. We've seen a 44% increase in provider satisfaction and a 27% decrease in the patient-reported fear of surgery over the course of the program. Overall, through our partnership with the Las Minas Health System in this programmatic area, more patients are seeking care and hospitals possess an increased ability to meet this new demand. As we move forward with more programs, impact assessments and lessons learned from our health system strengthening projects throughout the world have directly led to an improved understanding of key objectives needed for sustainable models of care delivery. Hospital partnerships provide sustainable infrastructure that is already integrated with the current health system. This helps us to assure program implementation fits local needs rather than external assumptions. It is through the identification and support of local champions that sustainable relationships are formed and bilateral and honest communication can occur. We've gained insight into the true needs of medical providers of the local systems where we partner with and support, and then through financial support of equipment and supplies, continuous education delivery, mentorship and research, leadership training, we can intentionally help to lift the local system to organically reach its full potential and decrease dependency over time. Operation Smile is also moving towards decentralization of our offered comprehensive cleft services. We're creating new care models to directly decrease barriers to care for our patients so they no longer will have to travel 12 hours to the capital city where our main offices are located. But now, through intentional hospital partnerships, we're delivering needed services closer to where our patients need them, thus increasing the likelihood that patients receive complete care and allowing families to not have to choose between their job and putting food on the table for their family or obtaining the surgical care their child with cleft needs. As we move forward with local system partnerships, we're generating long-term engagement. We're moving away from only implementing the short-term surgical program model and moving towards sustainable partnerships to help lift the surrounding system. And really, the message that I'm trying to get across is that NGOs can provide the solutions to the disconnects I previously mentioned. Academia has really been focused on the data collection and the baseline understanding of the systems and the care delivery where we focus, but NGOs are expert implementers. We have the financial support, the global distribution of human resources, experts in strategy and operations, and there's truly an opportunity to seek out more intentional relationships and partnerships between academia and NGOs to progress further together than we could individually. How is Operation Smile's data collection contributing to the surgical indicators? Our organization over the last few years has intentionally restructured to allow for greater progress with key stakeholders that align with the vision of the organization and the global surgery community. Our key performance indicators are directly associated with the accepted surgical indicators globally. We've recently implemented new organizational products, such as our new patient health record, and we're utilizing globally accepted data collection tools like the hospital assessment tool created by the Program for Global Surgery and Social Change and the WHO, to allow for more programmatic data collection that not only allows us to better understand the impact our programs are having over time, but also allows us to inform and contribute to local, regional, and national data systems as a way to provide insight into what programs are moving the dial forward in relation to accessing the preparedness and the cost of surgical care within the areas and countries we work around the world. It is then through these strategic partnerships that this data can be shared and evaluated to allow for inclusion of data and information that is no longer absent of marginalized patients in hospital systems without the previous capacity to collect comprehensive and quality data. This is so important because as we advocate for policy change at a central level, it's important that those decisions are made on data that is as inclusive of the general population rather than only populations in large urban centers where human resources are plentiful and data collection is less challenging. So where do we go from here? We must continue to advocate for a collection of surgical indicators, as we must know the baseline to know progress. As Maria and I have already discussed, there continues to be fragmented, outdated, and non-centralized data sources for trying to understand the surgical indicators throughout LAC and throughout the rest of the world. There are many on this call that continue to advocate for this, but we must understand that we must move forward now with implementation of programs so that when baselines are understood, we can hit the ground running with interventions that have been tested and we know work in the local context. However, if we wait to plan interventions until we know the baselines, we will not reach the goals by 2030. We also must have a top-down combined with a bottom-up approach. From the top, there must be a change in the balance between external support offerings from academia, NGOs, social philanthropists, and internal requests from governments and ministries of health. When there are more external support offerings, it may provide insight that key stakeholders within the government or Ministry of Health don't truly grasp the problems that those on this call understand and grasp regarding the barriers to surgical care and the economic costs of not scaling up surgical systems within their respective countries. Again, the global surgery community is a relatively small group, and we must break out from these small groups and figure out ways to be more inclusive of those not exposed to the literature, not exposed to the research, and the work many of us have completed or are continuing to work on. And from the bottom up, local champions must drive the change. They must be the grassroots that take hold and create a strong foundation for change. Without them, the work is not sustainable. And I know local championship is discussed throughout the literature and everybody says, of course, but with Operation Smile and other experiences, I've seen the shortcomings of programmatic work when local championship is not intentionally integrated from initial implementation. And finally, NGOs can be the bridge to implementation. Academia have been pivotal in creating this global surgical movement, but in business, we must know our strengths and understand our weaknesses. A hard lesson I learned in another startup I had was that the most important thing is your team. Without a solid team that complements each other's strengths and weaknesses, it is close to impossible to succeed. Academia, governments, and ministries of health can be complemented with the support of NGOs that are answering the call and expanding the models of care to answer the global surgery agenda. And we must partner together to be leaders in the effort to educate those outside our field to recruit unique partners that can help us accomplish our goals. Academics are experts in research and data analysis, whereas NGOs are experts in implementation. These partnerships can take data and models and transform them into proof of concepts and prototype projects, interventions, or products for building surgical capacity and improving the overall strength of the system. And together, we can better critically evaluate our creative programs to determine local solutions to the global problems we are looking to solve. But then the question is, how do we succeed? We must be strategic in forming multidisciplinary teams that fill the needs of the systems around us. We must think outside the box of our traditional thinking, and we must keep our minds and eyes open to be inclusive of those that share our vision forward, as a key partnership may not be known until it is presented in front of us. Perhaps through broader education of global surgical need and generation of increased knowledge of the demand, those partnerships will surface. We must also seek out intentional implementation of programs. Operation Smile, other NGOs, we do things a little bit backwards, which for me, coming from an academic institution, has been insightful, challenging, but also exciting because it forces us to determine solutions and program impact within real world situations. Because our primary mission is to deliver care to the patients with the greatest need, or any need, we approach data collection and research a little backwards. In academics, you create a question, you form a hypothesis, and create a research plan for how to objectively collect data with as little bias as possible to determine if you will accept your null hypothesis or not. In the NGO world, we set key performance indicators and execute on monitoring and evaluation to understand progress and impact. It is after we collect the data that we look for the research questions and the opportunities to understand the systems where we work. NGOs are good at M&E, academia is good at research. Thus, we need an increased amount of intentional and strategic partnerships to create a middle ground to best implement projects to truly understand impact, sustainability, and scalability. And finally, how do we sustain this vision? Younger generations are looking to make an impact. Early mentorship and support is meaningful. Don't underestimate the power of a single moment in time for a young innovator, an inspiring physician, an entrepreneur, a social impact investor. In 2016, when I was a third-year medical student, Dr. Peck, which was the senior author on the paper that I first presented, sent me a paper to read. That paper was Global Surgery 2030. It changed my life and my career trajectory. One paper did that. That paper led me to seek out opportunities to live in Colombia at different times throughout my third and fourth year of medical school. And this early field experience reaffirmed my decision that global surgery was a career path that I envisioned for myself moving forward. One conversation or one paper can change a perspective. Take that 30-minute call from a medical student that reached out to you on Twitter, or provide alternative views to improve the systems we work when rounding with residents. You never know who your words will inspire, and truthfully, a regular conversation to us could be the spark that ignites a flame in a future leader within this field of work. And finally, I just want to leave you all with a quote, and I encourage you all to read this recent article published by Atul Gawande in the New Yorker. And the article, it's an inspiring read in which so many ideas can be generated around how public health, community health, and individual health can grow organically together rather than individually improved. And while this article is about basic healthcare, it made me reflect on the parallels with accessing basic surgical care and services, and where we together can be leaders in changing our model of care to sustainably reach more patients closer where they live, while also simultaneously bolstering the surrounding healthcare system. This one quote was very inspiring. I hope it inspires you as much as it did me when I read it. It is possible to change the picture. It is possible to call upon a group of people, a group of Quixotes. Do you know Quixote? Who think and can see 20, 30 years ahead. It is possible to raise an idea and see it supported by a younger generation to become real. I am that younger generation, and we must continue to inspire and educate the generations after us if we are to be successful at achieving the goals set out for us by those before us. So thank you very much. I appreciate you listening to Maria and I, and we welcome any questions.
John and Maria, this is Dan Peterson. Wonderful presentations. Thank you so much. And I'll start things off with a question. You know, you talked about, both of you talked about the gaps in getting the data to do a meaningful tracking of these indicators. And my question is, both of you talked about the need for basic fundamental primary data collection at the source, at the individual patient level. And for sure, that's needed to do this right. I'm wondering, can more be done with data that's already being captured now, that's not making it up through the system for these kinds of measures to be tracked and updated with less difficulty than you guys talked about how difficult and expensive and time-consuming it was to do the data analysis you did, even without the ideal data? Can more be done with the data that's being captured now?
I think that's with the assumption that more data is being collected than what you see at a national level. You know, in working with some teams in Nicaragua and Madagascar, the data they report to the Ministry of Health is what is required by that hospital. And so when we as a program have come into those hospitals to try and collect more data, we've met a lot of resistance, or it's taken a lot of resources and efforts to try and train them on, we want to collect this additional data that aligns with surgical indicators, and then provide that why as well, why we're doing it. And then it's constant monthly feedback, validation of the data. Let's improve this area, empowering our M&E coordinators to provide that feedback to the local data collectors so they can build their teams. So I think it's a little bit of a combined approach. I think it's an understanding of what is happening at the local level, but you really do need that top-down approach, that policy from the top saying, hey, we are going to support this data collection from a central standpoint, and then have those local hospitals support that and collect that data. Because if there's that disconnect, it's really hard to generate that from the local level and move that up the chain.
Sí, en principio yo creo que hay muchos hospitales
In principle, there are a lot of hospitals that do collect data, especially in the larger cities. Many do have surgical indicator collection, but the health ministers at the national levels are not demanding that data. It may be that in some regions they have it, and so others they don't. It's inconsistent. So we did the whole process of base analysis, but there was only data from certain regions. We didn't have national data. So once the National Health Ministry requests and demands the data, they can gather all of this data more easily. Many hospitals that do report the data but that data is not available to us or to researchers.
Thank you both very much. That's very helpful. Other questions? Who else has questions for John and Maria?
Hello, this is Monica Langer, and I really enjoyed the presentation and congratulate you both on what you've already been able to accomplish. I think I've been working with the tracking indicators group with the G4 Alliance. And in order to get really robust indicators, I agree that you do need a lot more data. But we did find that with our group that we were able to use some data that's collected already, maybe for different purposes, and use that for tracking indicators. So for example, we used medical licensing registries for countries to be able to get an estimate of, a pretty accurate estimate of the number of specialist physicians in a country. And that's often publicly available. So there is maybe a few ways around it for some of the indicators, I think.
Sí, por ejemplo, en el estudio que mostró John,
Yes, for example, in the study that John showed, it was with the support of North American universities, working with Bogotá and Medellin universities in Colombia. And they did some field research, went to the different hospitals to find data from the six indicators. And that was a 2-year project. But now that it's 3 or 4 years later, once again, we don't have data, updated data from those 6 hospitals. So our idea is to lobby so that these indicators are collected as a public policy, so that this is something sustained over time.
And I would agree. You know, there's definitely ways to go around and figure out the indicators where they are now with various data sources, but that can be time intensive to finding all those national registries and putting everything together. And it would just be really nice if we had a centralized data source from a government level to say, hey, this is an important information that we need to know and understand the progress we're making. And so it required reporting from all those agencies into a government reporting system that is clearly visible for the people engaging in this work and research to understand what progress is being made over the years we're doing this research and program implementation.
I agree. It would be much better if we had more robust
Sure.
data. I think that that's a great goal. I'm not sure we'll get there before 2030, but I appreciate the efforts, definitely.
Yo tengo
And I
una
would-
duda.
Go ahead, Maria.
Tengo una duda, una
I have
pregunta
a question. regarding
en terreno.
the
Mencionaban el
field process. You mentioned, for example, Nicaragua, that you had people trained to do surveys
en terreno.
and that it was more of a field effort. Could you describe a little bit how you trained of these survey takers? How did they do it? Where does the information go? Are each of them entering it into a database? How is that field work done?
So thank you for the question. I switched over a little bit. I got most of the question. So that project, we have standardized data collection tools. We have basic surgical volume information that we collect every month, but we have hired surgical data collectors that are in that hospital and going through the surgical logbook, patient files, matching data, validating that data. We also go through and we do provider satisfaction surveys, patient surveys on a monthly basis. And then we also do hospital assessments every 6 months to understand the progress over time. We've been able, the information that is collected in the hospital regarding surgical numbers is actually very good. It's vastly different than a hospital in Madagascar that doesn't collect procedures or cases. They only collect information on pathologies treated per month. So the baseline data that is collected in the hospitals in Nicaragua is very good. It's just a matter of processing through that, running through the data, and then putting everything together. And then also working with our teams monthly to look at that data, speak with them, ask questions, have them work with their local hospital teams. There's a lot of work that goes on a monthly basis, but we have our data collection tools that align with what is also collected in the hospitals.
John and Maria, congratulations for such a great presentation. My name is Diana Arquiaga, and I'm the program director for Smile Train South America.
Muchísimas gracias.
Encantada.
Gracias.
Listen, what I'm thinking is that maybe we should create this is a space that we all gather different organizations, and I'm a psychologist, I'm not a surgeon, but I certainly have great surgeons in my team. I have several surgeons in Colombia, and you know how our countries work, and maybe we can create from this effort, a coalition. This is the idea of these meetings, and put together a team that maybe we can start knocking on doors. And the idea is to get to what our purpose. No, I mean, maybe forget which hat are we wearing and wear the G4 hat alliance to obtain the purpose, the investigation, and get the numbers that we need, and join efforts, and forget, I mean, of course, I'm Smile Train and you're Operation Smile, but you guys did a great presentation. And this is what we want to obtain, the data that we need, because ultimately, this is going to help the patients that we all want to serve. So maybe this is something that certainly I can bring some of our surgeons. I don't know, Sarah, it's over there somewhere in the team, and Christian Henry as well from Smile Train. Now maybe we can do talk to Erin Steiber up above in the organization, and for sure Ruben Ayala, I guess, will agree. And there's Dan Peterson, and somewhere else is from S Surgery International. I'm bad with names, but anyway. Jody will agree, I guess, to this. Maybe we can definitely knock on doors and get together and work on a strategy, because we have different relations in our countries, and we for sure will make things happen.
Yeah, a lot of this work is not going to be achieved individually. Exactly. Partnerships create results, competition sequesters it. Exactly. So, you have to move forward together. I mean, through partnerships, as I talked about. But even within the same field, there have to be partnerships to understand and help each other move forward.
And ultimately, this data will help everyone, us, other organizations that work with heart or whatever other specialty they do, it's going to help the medical field regardless,
Yep.
So
I think it's, especially from an NGO perspective where we have a lot of donor money, I think it's important to share with each other what hasn't worked. So that if we implement a program and it hasn't worked, that what that program was, so you're not wasting programmatic money on something that we know has failed within the same context. Those things are just as important in as well as those partnerships to move things forward.
Maybe we need to look at it from a bigger perspective.
Sí, y añadir, Diane, gracias. Añadir que finalmente no trabajamos solo para la comunidad médica,
Also, I want to add, we don't work just for the medical community. We work for the patients. They're the ones who ultimately need to benefit.
en Bogotá, Colombia.
Where are you from? Are you in Colombia?
Estuve en Bogotá de jueves a domingo 5 veces por paradas y cambios de aviones.
Qué bueno, qué bueno. Pero soy boliviana originalmente.
You know, I just add a little more from the comments made. It seems to me that there's a couple different approaches to achieving this goal of capturing this data. Number one is to try to identify those countries, one or two countries, that we think we have the best chance of getting such a mandate, and get that in place in one or two countries to be able to show other countries, look at what the value is when you look at the insight and analysis that can come from it. Okay, so you don't try to get 14 countries at once, you get 2 or 3, okay, or
Maybe
one or
one.
two.
Or maybe one,
Okay,
only
either
one.
one. And
Exactly.
you go from that. Another
Mhm.
approach we could take, okay, the mandate is the end goal. But in order to get the mandate, if we could show that it's in the best interests of the data collecting institution, if we could show that there's value to them of collecting this data, then we start the snowball effect within the country. We have a few institutions that collect this data. They do benchmarking. They see how they're performing, and they see value. And then other countries, other institutions in that country start to collect as well. And we start at the institution level to roll up. So those are just the two thoughts that I had in terms of how to get to the goal that John and Maria described so well of multi-country mandated data collection.
Sí, y la colaboración regional es muy importante también. Como dicen, podemos comenzar por un país, por dos
Like you
países.
say, we could start in 1 or 2 countries and then show what the experience has been in that country and show what programs work, which don't. And then based on that, we can support the countries that are more behind.
For the country in which the study will be done, because that will help for public policies, you know, for many things, know how many hospitals they need, what kind of specialty they need, what kind of universities, you know, what kind of specialties, more plastic surgeons, more head and whatever, neck surgeons they need, more OBGYNs, whatever it is, you know, I guess to plan better, you know, anesthesiologist. So I think.
Sorry, I didn't mean to cut you off, Diane.
No, you know better.
No. I think one of the hopes was from the situational analysis that came out of Colombia, that would provide the impetus to show the value in collecting the surgical indicators, because previously everybody just said, well, let's collect the indicators, but there's never been a why. So they contextualize it, they put the why behind it, but there's just been this lack of momentum that followed it. Maybe it was COVID that hit. You know, this paper came out in February of 2020, and then COVID hit. You know, this group had gained a lot of momentum. We had been in Colombia for a very long time. We were having national meetings, and then COVID hit and things kind of dropped off. So maybe we can regenerate that momentum from there. But really, that was the idea. You have this strong healthcare system in Colombia. They have a pretty good data tracking system. They believe in universal healthcare and healthcare as a basic human right. You know, the building blocks are there to do it in Colombia, and it's a great country to move forward with. And that was the hope, I think, of this paper. And we just maybe need to go back to that, find those key stakeholders, regain the momentum, and continue to move forward.
I was going to mention that because Colombia has good infrastructure in terms of hospitals. I travel all over. So versus Peru doesn't have that. And I'm based out of Peru right now. So Peru doesn't have that, and Ecuador is too little in that sense. Bolivia too, you know, I think Colombia is a good sized country with good hospitals wherever you go, you know, in the main cities is definitely good hospitals, so good teams as well. So I think it will be a good country to start and take it from there in the region, you know. Replicate replicate that study. So what's next? What do we do next?
You know, I think, see, I think I've mentioned it in the presentation. I did mention in the presentation, but really those partnerships. I think, you know, NGOs have one academic partnership. You know, Operation Smile is connected with the University of Southern California. JPIGO is connected with Hopkins. Lifebox, their chair is Atul Gawande. So it's like an informal of Harvard and Brigham and Women's Hospital. I think it's okay if an NGO has more than one academic partner. And academia has more than one NGO partner. There needs to be more partnership to move things forward. Like I said, you know, it's been a really eye-opening experience to be a global surgery fellow with Operation Smile because of the global programs we implement all the time. And I'm sure Smile Train does the same thing. You're constantly seeing what are the gaps? How can we get care to more patients? How can we deliver more surgical care? And it's a similar thing on Operation Smile side, but how can we intentionally move forward with the academic institutions, the ones that have really pushed this global movement to come up with not only the programs, but the projects and able to collect that data with the data that's already there to understand more impact and more sustainable change. You know, we're really, like I said, we're really good at M&E, but we need that academic support to really understand that data analysis and really understand to find those nuances within the data to help us move things forward. So just more partnerships.
And also with local partnerships with
Totally.
a big local university. I think that will be important. One of my partners, Dr. Juan Carlos Zambrano, is from Universidad Javeriana. So I think that will be important with a local partnership, you know, a big hospital, San Ignacio, that's a very important university there, a very good hospital in Bogotá. So those are the kind of very good surgeon as well. That's a doctor I'm thinking of. He's part of my SAMAC, my South America Medical Advisory Board. He will be the one that I'm thinking of to be part of this team.
Él fue mi profesor en cirugía plástica.
Ay, divino.
4 años.
Divino, lo adoro.
Así que ahí está la relación y claro, la idea es trabajar todos juntos.
Yes, the idea is everyone working together, link research groups, global surgery groups who have developed since 2016.
And through partnership with the academia locally in Colombia, maybe we can get partnerships with residents so they can help us collect data, you know, interns. That's something that we can, we have several teams in Colombia, so locally, so I guess that would be interesting. Anyway, maybe we have to ask higher above, but I think it's a good cause. Maybe we need to really join efforts to do something really nice, you know?
Claro que sí.
Absolutely.
Dan, do you want to start wrapping up?
Are you there?
I would love to. Once again, this working group just knocks it out of the park month after month with the First Tuesdays events. A huge thank you to John and Maria for their insights and for sharing them with us, and for the team that organized this. Thank you both for coming here and telling us about this work. Thank you, Operation Smile. Thank you, everybody, for taking the time at the end of your day to dive into this issue. We've got a long way to go, but we could see we're making progress. And I look forward to the Latin American Caribbean region, really blazing the trail here in tracking surgical indicators, that this can be something that sets an example, a model for other regions in the world to follow. So that's really, one of the dual objectives of this working group is to both rejuvenate or energize people within the region, but also to show people outside the region what's happening within the region. And this is a great example of that. So thank you, John. Thank you, Maria. Thank you, Jody. Thank you, everyone. And we'll see many of you at the Permanent Council meeting the day after tomorrow. If you don't have an invitation and you want one, shoot me a text message. I'll put you on the invite list. We always like to have more. Permanent Council meeting day after tomorrow. We've got a couple events for the UN General Assembly coming up September 20th and 21st. Hope to see you all there.
Great.
Muchas
Thanks so much,
gracias.
everybody. Thanks so much, Jody,
Very much.
Dan,
Bye-bye.
everybody.
Bye-bye, John.
care.
Thank you, Maria. Encantada. Bye-bye.
Encantado.
Bye-bye.
Gusto.
Very inspiring today.
Very much.
Bye-bye.
Shows we can make progress. We can keep moving it forward. We keep pushing the ball. I know we're pushing it up the hill. It's a little slope here, but we're pushing it up the hill, and we're going to get stronger and stronger with each roll.
But really, if we want to make a difference, that's what we need to do. We really need to join efforts and put all of us to have the same hat. What's the main, what is it what we wanted to achieve? Not only to look within the organization that we represent, that is true, but if we achieve the results of that's what we're working on this group, that's exactly, it's going to benefit us all.
Yep. It will. Thank you, Diane. See
You're
you
welcome.
again. Please join us again.
I will. Bye-bye.
Okay.
Ciao, ciao.
Bye-bye, everyone.
Ciao, bye-bye.